Hello everyone, I'm Sarah Grant and I am going to be speaking today about delirium as cited in the DSM-5. I'll be using not only the DSM-5 criteria, but also I will be giving a little bit of information out of the book, The DSM-5 Made Easy, the Clinician's Guide to Diagnosis. So the DSM-5 puts delirium right after the chapters of substance abuse and gambling disorder, which there's a good reason for that, I believe. But before we get into that, I'm just going to kind of give you the diagnostic criteria, and there's 5 of them that the DSM-5 cites for diagnostic criteria for delirium. The first one is a disturbance in attention and awareness. So attention they identify as reduced ability to direct, focus, sustained, or shift attention. So how easily is it for someone to follow along with a conversation or be able to follow along with different ideas? And the awareness, reduced orientation to the environment. So really looking at those 3, sometimes 4 criteria of person, place, and time. And are they able to identify those things? The second criteria is the disturbance develops over a short period of time, usually hours to a few days. It represents a change from the baseline attention and awareness and tends to fluctuate in severity during the course of the day. And this is one of the biggest things to keep in mind is delirium is something that happens rather rapidly. It isn't something that progresses over a period of time. It's something that can happen pretty quickly and can be quite scary for individuals who haven't experienced it, or for individuals whose loved ones are experiencing delirium. So just keeping that in mind, that it's something, these symptoms are happening rather quickly. C is an additional disturbance in cognition. So they might struggle with memory, be disoriented, which we spoke about just a little bit ago. Their language might be impacted, so maybe they don't remember certain words, or it's difficult for them to express themselves, or it might come out mumbled or disoriented just in their speech. Visual spatial ability or even their perception can be off. So perception meaning cognitively their perception is off, but it also can impact what they see as well, or even hear. The 4th criteria is the disturbances in A and C. So remembering that A is a disturbance in attention and awareness, and C is an additional disturbance in their cognition. They're not better explained by another pre-existing, established, or evolving neurocognitive disorder. So when you think of other neurocognitive disorders, you're thinking of like they haven't been diagnosed with Alzheimer's disease, or they haven't been diagnosed with other cognitive inabilities. So things that make it difficult for them to be able to do that, which they've already been diagnosed with. And then the 5th criteria in the DSM-5 for delirium is there's evidence from the history, physical examination, or laboratory findings that the disturbance is a direct physiological consequence of another medical condition, substance intoxication, or withdrawal. So it might be due to drug abuse, or it might be due to when somebody is withdrawing from alcohol, they might experience delirium. It might be due to another medical condition. So for instance, someone who has type 2 diabetes might experience symptoms of delirium if their blood sugars are really low. It also can be due to exposure to a toxin or due to multiple different things. So when you're thinking of substance use, thinking of methamphetamine, and the patient might not know what was in the methamphetamine that they use. So there could be several things that are going on that are causing the delirium. Then after you've made that diagnosis of delirium, there are also specifiers that you can add to that as well. The first is that you want to identify if it is substance-induced or related, and the coding changes depending on what the substance use is specifically. It can be due to substance withdrawal delirium, medication-induced delirium, kind of like what we spoke about, delirium due to another medical condition, or delirium due to multiple things. So if there's more than one of those, you can code it that way as well and then put that specifier behind it. You can also specify if the delirium is acute meaning that it lasts in only a few hours or days and then the delirium is over. So many people who are withdrawing from alcohol, for instance, might be under medical supervision in the hospital, and the delirium is just short-lived as they go through that withdrawal, or it could be something persistent that has been lasting for weeks or months. And just remember that when it came on rapidly, but it could actually last longer, and you can specify that with acute or persistent. You can also specify the delirium in that whether or not the individual is hyperactive or hypoactive. So hyperactive meaning that they might be really irritated or agitated, resist medical attention. Their mood might be really grandiose. Hypoactive is when psychomotor activity that is coming about, like being sluggish, as it says in the DSM-5, or they're lethargic, they might slur their words, that sort of thing. Or you can even specify that it's a mixture between those two. Delirium can also be accompanied by sleep disturbance. So someone who is experienced delirium over several days or several weeks might experience insomnia when they didn't have it prior. They might experience sleepiness during the day. They might have their sleep cycle is just really off. They might sleep for a little while and then get up and then sleep for a little while again. The prevalence of delirium is highest amongst older individuals who have been hospitalized. And actually that is also one of the risk factors, or prognostic factors. Environmentally, delirium may be increased for individuals who are immobile, may have a history of falls. So thinking about, again, the older population, thinking of individuals who live in colder climates might have a history of falls. They have lower levels of activity often. Those have been diagnosed with delirium. And also when you're looking at the population who has substance use disorders or are on medications that could cause some symptoms of delirium. And any of the substances that have psychoactive properties. So when you're looking at like alcohol and that sort of thing. There are two other diagnoses for delirium. There's other specified delirium and then also unspecified delirium. Other specified delirium is when an individual may have some of the symptoms out of those 5 criteria, but not all of them, and you still want to communicate to other professionals or to other people working with this individual that they have some of the symptoms but don't meet full criteria. Also, with other specified delirium, you are putting specifiers on that diagnosis as well, not just having that as it's on its own. If you're wanting to use unspecified delirium diagnosis, that is communicating to other professionals or other individuals who work with this patient that they fall short of meeting all criteria but meet some of the criteria, and then you don't put a specifier on that diagnosis. So other specified delirium, you put the specifiers. Unspecified delirium, you're not putting specifiers. Now looking in the book, DSM-5 Made Easy, the Clinician's Guide to Diagnosis, on page 474, chapter 16, it goes into some explanation of delirium. And in this book as well, it is placed right after substance use disorders and gambling disorders, which is not on accident. It is due to because many times when people are using substances, they may experience delirium, or when they're withdrawing from certain substances, they may also experience delirium. One thing to really remember about delirium in regards to how it's different from other neurocognitive disorders is that this is something that develops rather quickly or rapidly, fluctuating state of reduced awareness in which the following are true. So just kind of a recap. The patient has trouble with awareness and shifting of focus or attention, and the patient has at least one defect. So one out of these: memory, orientation, perception, visuospatial skills, or language. And it's the symptoms are not better explained by a coma or another cognitive disorder. So if they have another cognitive disorder and are experiencing those symptoms, then it's not delirium. Delirium is experienced for other reasons, and again, very rapidly comes on. And it's caused by one of 4 of these reasons, due to another medical condition, due to substance intoxication, or withdrawal or medication-induced delirium. So certain prescribed medications can also result in delirium, or multiple reasons that the person has delirium. So somebody who may have a medical condition like type 2 diabetes, has an alcohol use disorder, and is in the hospital, for instance, for withdrawal, may experience delirium due to the alcohol withdrawal, and also because their blood sugars are low. And then again, that other specified or unspecified delirium is also an option. So for the rest of our presentation, you will be able to view a short clip of delirium explained again, and then also there will be a video about an article that we did some research on in regards to delirium, and then also the information on that article. So I hope you enjoyed this presentation, and I gave you some information and a little bit more clarity of what delirium is. Thank you.